All right. I think some of you also receive the Harvard Public Health Journal email that comes, I think, weekly. Did anyone see the article that mentioned Medi-Mom? Did anyone else read that? I actually received the article from several people and knew because of that circulation that we needed to have a conversation with you today, Veronica. So I'm going to ask that Veronica first tell me a little bit about yourself and also your interest in maternal health broadly.
Yeah, absolutely. Let's see if this is working. Okay, that was an operator error. Hi, nice to be here, and thank you so much for inviting me, Joy. So my name is Veronica Adamson. I'm a maternal and child health innovation leader, so I really focus on the innovation side of maternal and infant health. I spent most of my career in the private sector, bringing technology innovations globally to millions of women and infants, but more recently have actually transitioned into looking at how do we enable the system of healthcare that we deliver to women and children to actually be better. So really looking at the system level. So I run a think tank called InnovaHer that actually spun out of the Harvard Maternal and Child Health Center of Excellence, and it's really focused on helping innovations actually go from idea to commercial scale. So really thinking more broadly about what it's going to take in a space where this ecosystem is broken. But Medi-Mom, what I'm here to talk about today, is actually deeply personal. It's not just professional. Like many families, I experienced the gaps in maternal and child health firsthand. So I almost lost my son to stillbirth. And it really opened my eyes to kind of the gaps that we have in our system. And I know I'm not alone. I know that a lot of you here in this room have experienced the gaps in the healthcare system, and that, like me, you know the statistics of just how bad things are. I don't think I need to say that again on the maternal health side, but also on the infant health side. So we have 20,000 stillbirths a year in the US, which is really a shocking number, and for the first time in decades has actually stopped decreasing. So that's very concerning, obviously. And when we look at those statistics, you know, this really drove my interest in maternal health. But what keeps me up at night and really drives my passion isn't just my personal experience or the statistics, but that I know that we know how to solve this, that together we can solve it. And that's what really motivates me in the space, and what was kind of the impetus for Medi-Mom and for what I do today, which is really focused on driving both the system level change through collaboration, not just in academia, but with the private sector, with advocates, with the community, and then really trying to help innovations that can be game changers. We heard from a few of them earlier, to actually come into being. So work around the barriers in system change.
Very good. So it's Medi-Mom, not Medi-Mom.
It's new. It can be whatever you want it to be.
It's a concept, but it feels really important to unpack novel concepts like these, particularly because Medicaid is at risk, and we certainly hope Medicaid is not going to go away. But do you want to talk about Medi-Mom a bit more? And so it's a play on Medicaid, Medicare, Medi-Mom, Medi-Mom. So tell us, what is Medi-Mom? Tell us about the article and what is Medi-Mom? What is it aiming to solve?
Yeah, thank you. And I'm glad that you got the play on words, because that was the goal. So Medi-Mom is really the idea that the system that we have today, the Medicaid structure, not the people working in Medicaid that work really hard, or, you know, the people in the states or the providers, but really the structure of this system doesn't actually work. And I came to Medi-Mom in kind of a roundabout way, with a canary in the coal mine type question. And that question was this question around stillbirth. If we have 20,000 stillbirths a year in the US, and yet we still use technology from the 1960s to try to detect stillbirth, how can that be? How can we not have made an innovation that's so simple to make? And in looking at that question and diving deeper into the research, identified that it wasn't one thing, right? It wasn't just that there wasn't maybe the right reimbursement for the technology, but as mentioned earlier, the OBGYNs themselves are not reimbursed sufficiently to think about innovation, right? That there isn't enough coordination of care for innovation to take place because there's no one to really pass it off to the right people. So kind of the structure that we have and the gaps in accountability in Medicaid just wasn't enabling a system that would promote that innovation. So that's kind of where Medi-Mom came from, and I can talk a little bit more about what it is, but that was the impetus.
I'm going to read this this statement from the opinion piece that was in the Harvard newsletter. It says Medicaid makes coverage decisions without prioritizing the data necessary to understand the problems. For example, it discourages hospitals from providing care by pushing them into bankruptcy. And I know there's a couple folks, Greg, in the room. Further, it fails to offer coordinated medical services. We heard about care coordination earlier, to deliver urgently needed healthcare information to patients or ensure the adoption of new life-saving technology. So that's how we're seeing or thinking about how Medicaid might be failing probably all patients, but in our case, we're looking at mothers. You are really highlighting in my mind the fact that coverage doesn't equal a system of care. Coverage is just coverage. The big difference in your proposal, from what I read, was that this is a federal program that would be administered at the federal level. Can you talk to us a little bit about that vision?
Yeah, absolutely. So we already have in the U.S. plans for specific populations, right? So special needs plans, Medicare Advantage type plans that really hone in on specific populations and their specific needs. And those programs are actually organized and to some degree operated at the federal level. So it's a mix of federal and state level. And that's important because by focusing on populations, we can actually hone in on specific metrics and milestones that we need to achieve for that population, which means that we can hold plans accountable. And that's a really important differentiator from where we are today. The second piece that's, I would say, pretty different from where we are today with Medicaid is that these plans, if you can imagine something similar in pregnancy and in infancy, are that they provide a backbone of comprehensive care. So it's not just, the treatment, but also making sure that it's accessible throughout the journey. So being able to be preventative. And the last piece is really the technology component of it, which if you look at the reimbursement available, for example, for Medicare is quite a bit higher. There are specific reimbursement programs for technology. And that's why you see, for example, new cardiology devices coming out every 6 months, where we still have fetal monitors from the 1960s. So it's really a technology first approach that could be enabled through this slightly more federal lens. So it's a pretty different proposal, but not one that's completely novel to the system that we have today.
Got it. Remind us, how would it be set up? Network providers, federal contracts with large payers to administer it? How would this work?
Yeah. So I don't want to try and give too much detail here because I'm sure there are people here who know a lot more about this specific space than I do, but I'll give the highlights. So essentially, the way that I envision it running is that it would be a plan that is much more like a Medicare Advantage or a special needs plan where you actually pay for performance. So it's very much of these are the metrics that you need to achieve, and then plans need to achieve those metrics that are set out at the federal level. And then run through a collaboration with states. So I don't go into a lot of detail, but it's a much more streamlined way of basically paying for performance. I would say the trick here and the magic in the sauce is figuring out how to make sure that it actually works for clinicians and for communities and for doulas and everybody. That pay for performance is actually effective.
God, I think the Medicare Advantage analogy is a helpful one as people know that model. And I hear Dr. Oz, new director of CMS, administrator, likes Medicare Advantage. So an interesting concept to think through. What else should we know about the aims for Medi-Mom? And actually, let me just throw in one more comment. I actually think in our U.S. healthcare system, one of the biggest problems, we have some alignment, a lot of alignment with this component, is that we don't create measures for every clinical practice guideline and then payment incentives, right? We release clinical practice guidelines and then maybe there's a measure that was introduced 10 years ago that doesn't align. It's just a hodgepodge of nothingness. And so I think what your model is proposing is that there's structure around it. And as you said, population-based solution, just like Medicare Advantage, this would be Mom Advantage or whatever it might be.
Yeah.
Anything else we should know about the concepts?
I think one of the other key things and maybe a differentiator is trying to bring in some of the private sector best practices more into public health. So really setting up a program that can be more accountable for outcomes, which requires a different structure. If we the way that we have structured Medicaid historically, where it serves a lot of populations in a lot of different ways, it's very difficult to know early on how successful we are in terms of improving the outcomes that we want to. So the idea here is to really sort of centralize that so we can have really good visibility into what needs to change and how do we do that. I will say Medicare Advantage is a bit of a hot topic these days. I acknowledge that. It would need to be done right, but I think there is something there that can be both providing better outcomes, but also more cost effective. So we actually can act on both ends of the spectrum.
Great. Well, I know there are people that are going to want to talk to you, and the state Medicaid agencies might be like, no, we're not doing that, and no deal. But I think really important to be thinking outside of the box right now for all the reasons that we've talked about. So I want to thank you for joining us and coming all the way down from the East Coast to join us today, and really look forward to more conversations with Veronica in a bit. Thank you, Veronica.
Thank you, Joy. Thank you, everybody.